Thank you, Brian. Thank you, everybody, for joining us on for our April monthly on Mondays. I'm very privileged and honored to introduce our speaker today, Dr. Karen Hauer from UCSF. Karen and I are in the Executive Leadership for Academic Medicine program this past year, run by Drexel University. We were actually in a group together where we did a very interesting case-based project early on in our program, and I had the privilege of working with her. And Dr. Hauer, for those who don't know, she is currently the Vice Dean for Education at UCSF School of Medicine. She's been a faculty member at UCSF since 1997. She's had different hats, including Associate Dean for Competency Assessment and Professional Standards. She's also a professor of medicine. She's led and designed several assessment programs, one being the UCSF School of Medicine Bridges curriculum. She's also helped direct the School of Medicine medical student coaching program. And this work was recognized in 2022 by an International Aspire Award for Excellence. She's an active researcher in medical education and a research mentor for fellows, residents, medical students, and other faculty. And she has a focus on competency-based medical education, learner assessment, coaching, and remediation. So we thought she would be wonderful to give this talk for all the faculty on thinking about how we teach professionalism. And another thing that she's done is in 2015, she completed her PhD in medical education through a joint program at UCSF and the University of Utrecht in the Netherlands. And so she also serves in leadership roles on the National Board of Medical Examiners, and also has been doing some site mock visits for LCME, and she helped us with ours earlier this year as well. So without further ado, I'd like to turn it over to Karen.
All right. Well, thank you so much, Namisha, and all of you for inviting me to speak with you about this topic of professionalism. I appreciate the warm welcome. As was mentioned, I'm Vice Dean for Education at UCSF. I'm also a general internist in the Department of Medicine at UCSF. And the topic of professionalism has been relevant to me throughout my time as a clerkship director in internal medicine, and then as an associate dean for competency assessment and professional standards, and director of our medical student coaching program prior to my current responsibilities. We just had our accepted students weekend, where eager applicants accepted to UCSF School of Medicine came to see what we're all about. And that is a time when you see students' professionalism just exuding. They are so empathic, so excited, so engaged. And it made me think about this talk, like what changes during that time, and then the time that we say, oh, we think we're seeing problems with professionalism, or we think we're seeing people who aren't as professional as we would want them to be, or we hear our students say, you're holding professionalism against me. So what changes during the time that our learners are in our programs that professionalism goes from something that's being celebrated and appreciated to something that's being feared or worried about? It's a complex problem, and I'll share some thoughts with you about how we can get back to the place where professionalism helps us as educators to help our learners be prepared to care for patients. When we think about problems with professionalism, we typically think about the really egregious example of someone who clearly violated their social contract with our patients and their relationship with us as educators. But most of the time, the professionalism challenges that we see are a little more subtle. For example, during the pandemic at our school, we had a lot of discussion about professionalism with learners who were subjected to a Zoom curriculum when they couldn't be on site. What did it mean if they weren't turning their cameras on during a session? Did that mean that they were unprofessional? Well, as we see here, many of our faculty don't always want to turn their camera on. So that one is a tricky one. Another one is a student on a clinical service. What if their notes in the electronic health record are posted later than the intern or faculty member would want that to be posted? Is that a signal of unprofessional behavior, or is that maybe a signal of a learner who spent extra time with a patient and a family, or who was being asked to do multiple tasks by different supervisors and was feeling conflicted about where their professional responsibility should first manifest? So many of the times that a learner might be labeled as unprofessional, I think it's our responsibility to peel back the layers of the onion and understand a little more what the different ways of viewing the situation might be. I will invite you to think to yourself as we start this talk, for you as an educator, what makes it difficult to teach about professionalism? Why is it different teaching about professionalism than about our other competencies like medical knowledge or systems-based practice or communication skills? As I reflected on this question, I thought that one reason that professionalism can be difficult for me to teach is because situations can have so many different perspectives. So as you think about this question, what makes it difficult to teach about professionalism, I invite you to put any thoughts in the chat here so that others can see what you are thinking about teaching about professionalism. So today I'd like to cover these topics: professionalism definition, correlates of unprofessional behavior, challenges with professionalism as a construct, and our take-home points: promoting positive professional behaviors, getting back to our topic of teaching about professionalism. So what is the definition of professionalism? One of the reasons that professionalism is tough is that there is no one definition of professionalism in the field of medicine. I like the article by David Irby, who is a former vice dean of education at UCSF, where he tackled the question of what is professionalism. And he wrote about the fact that there are three possible frameworks that could help you define professionalism. One would be a virtue-based approach to professionalism. Does a learner have the right moral character, the right humanistic approach to be present for their patients? This is what our admissions committees are looking for when they look at applicants applying to medical school. A second approach is the behavior-based approach. Competencies, when we think about the ACGME competencies and milestones. What are the professional expectations? How do we phrase them in behavior-based terms? How do we give feedback that we view as very objective and based on our personal observations? A third framework is professional identity formation. This view emphasizes the learning and development aspect of professionalism and the melding of who the learner is as an individual, what they brought with them to medical school in terms of their background, their identities, and how that is blending with their physician training into a new professional or physician identity. In this framework, the socialization, the people with whom the learner is interacting, are very important influences on their professional development. So I'm not here to say that one of these is right and one of these is wrong. I think that professional identity formation is an important part of defining professionalism within our curricula, but likely you would say under different circumstances, all three of these would have merit in the way that you think about teaching professionalism. This is a list of the professionalism definition components from the recent publication of the UME competencies for all medical students from the AAMC and ACGME. And you can see that this approach falls squarely in the behavior-based, aligned with competency-based education approach. So professionalism is these 11 different things. You demonstrate this, you use that, you adapt that. Helpful at times. Also, you could imagine this kind of list approach might make it hard for a learner to know, what do you really want from me to meet your expectations for professionalism? This definition is in the behavior-based category, and learners might wonder, what about virtue or professional identity? Depending on the framework that you are using to teach about professionalism, you would use a different teaching approach. A virtue-based, character-based approach shows up when we do things like have a white coat ceremony, when we ask our learners to take an oath as an emerging physician. Those symbolic aspects of our profession very much align with a virtue-based approach to professionalism. If we are in the space of competency-based education, we're focused on expectations, feedback aligned with expectations, and this is often where sanctions come in. If you say, this was the expectation, you didn't meet the expectation, if that happens again, there will be a sanction. In the space of professional identity formation, again, that is a very social view of professionalism, where learners are learning from the people around them and the interactions they are having. That's where you want to show learners positive role models. So, for example, in our curriculum, coaches who know the student over time, who support them throughout the curriculum. Places in your curriculum where you have reflection sessions where students debrief difficult situations with peers under the guidance of a mentor. Those types of activities would help a learner to see how their pre-existing identities are evolving into a physician identity. Another approach to defining professionalism is the 4I's framework. And this is one that we are using with our learners at UCSF because we have found that it is simple enough to be clear to people and also comprehensive enough to capture both the positive behaviors that we want to see and a way to have a discussion about where professionalism might be falling short of our expectations. So the 4I's of professionalism are integrity, involvement, interaction, and introspection. And again, whether you want to convey this as something that people are learning or something that people might be falling short on and need to be sanctioned for, that could lead you to phrase your examples in the positive or the negative. So with our learners, we take the aspirational developmental view and frame the expectations around the 4I's using positively worded language, what you should be doing or would be doing. So you demonstrate integrity as a professional as part of your professionalism by maintaining patient confidentiality, to representing your research data or your patient data accurately, by upholding policies around ethics. You demonstrate your professional involvement by arriving on time, by responding promptly when people ask you to return a page or to submit something. And you participate actively. When you show up, you're not just in the room, but you are engaged. You demonstrate professionalism in your interactions by communicating with respect and showing sensitivity and humility with all of those with whom you interact, your colleagues, your supervisors, your patients. And introspection captures the aspects of professionalism around discussing feedback, sharing feedback, receiving feedback, acting upon that information, reflecting on your performance with the goal to continue to learn and grow, as opposed to just to perform or avoid looking bad. So there is no one definition of professionalism, but we have found considering the virtue-based, behavior-based, and developmental professional identity components are all helpful. And for speaking about professionalism with our learners, the 4 I's framework is helpful. So let's now discuss correlates of unprofessional behavior. This line of research contributes greatly to a lot of the fear and concern that learners have about professionalism. The research on unprofessional behavior in medical school originated largely at UCSF with Maxine Papadakis, our former Associate Dean for Students, who did multiple studies that correlated unprofessional behavior in medical school with subsequent unprofessional behavior and disciplinary action for physicians in practice. This research got a lot of traction, and really the headline was that if you're unprofessional in medical school, you're going to be unprofessional in your career. So the problem with the headline is that it overstates the likelihood and overstates the frequency of these kinds of problems. So one of the studies published from this line of research is shown here from the New England Journal of Medicine: Disciplinary Action by Medical Boards and Prior Behavior in Medical School. This was a case control study including over 200 graduates of 3 medical schools who were disciplined by one of 40 state medical boards. So they were looking at people over a 13-year period using these 235 graduates and double the number of control physicians. And they found that predictor variables in medical school did correlate with subsequent disciplinary action. The predictor variables that were indeed predictive of future bad behavior in practice were having unprofessional behavior that was moderate to severe in the domains of severe irresponsibility or severely diminished capacity for self-improvement, so not taking feedback. They also found that low MCAT scores and poor grades early in medical school were also correlated with reporting to the state medical board. So this is important information and certainly grabs one's attention, but there are some caveats to not overgeneralize about this. The findings only applied to students with repeated severe unprofessional behaviors. It wasn't applicable to a student who once or twice had a more minor example of unprofessional behavior. And there are the counterpoints about how swiftly and severely we respond to unprofessional behavior because of the damaging effects of labeling. When students become labeled as unprofessional or likely to have problems later in practice, that creates problems for their self-esteem and for their interactions with supervisors, and also can lead to problems with bias because people have certain ideas about who might be unprofessional, and then that leads to stereotype promotion. So this research is important in that it explains the consequences of severe unprofessional behavior for a very small number of learners, but really shouldn't be generalized to mean that all learners who have less amounts or severity of unprofessional behavior will go on to have problems in practice. So let's move on now to think about challenges with professionalism as a construct. Many people, just like all of you at your institution, have identified that there are problems with professionalism as a construct. And here are multiple headlines illustrating the recognition of this problem, not just in the medical literature, but also in the lay literature. You see on the left of this slide a headline, "The Unbearable Vagueness of Medical Professionalism." In this article, the authors talk about, is professionalism meant to inspire our learners? Like I mentioned, that newly accepted medical student who's very inspired to be a physician, Or is professionalism meant to intimidate and be a tool to discipline people? The article talks about professionalism is a lofty ideal, but learners, especially learners of color and from other minoritized backgrounds, would tell a very different story based on their experience. The headline at the top of the slide, Professionalism, the Wrong Tool to Solve the Right Problem. This article tackles the professionalism dilemma through the lens of racism. And the authors talk about how professionalism can be used as a tool of social control to maintain the interests of the social groups that dominate medicine historically. So, taking an overly simplistic historical view of professionalism may lead trainees to feel like they are excluded. And so, their only choices are to either perform as if they agree with your definition of professionalism or to be marginalized. The article by Lucy, The Perspective, The Problem with the Problem of Professionalism, addresses the fact that professionalism, even back 10 years ago when this was written, was really being used to sanction and label people rather than to promote learning. So these authors say to get back to the space where professionalism is about learning, we could learn from our approach to medical errors and take kind of a quality improvement approach where it's celebrated to recognize, acknowledge an error, and try to learn and adapt to do better the next time. And the last one, on calling from privilege to professionals to cogs of capitalism. This is part of a series and a podcast in the New England Journal about how the current state of medical practice, which can feel very corporate, very productivity driven, can feel to physicians that it is at odds with what we are expected to be in terms of professionals who are empathic and want to spend time with patients. So again, pointing to the system as the problem. So professionalism has many challenges as a construct, and these are widely recognized. I'll discuss in a little more depth 3 challenges with professionalism as a construct. First, binary interpretations, which lead to weaponization of professionalism. Second, generational views. And third, equity. Binary interpretations of professionalism means that people are labeled as either being professional or behaving professionally or not. And this leads to misuse of the construct because it's very quickly then a tool to control people or to marginalize or punish them. If you're not professional, all these bad things therefore can happen. This also diminishes the emphasis on the possibility to learn and grow from a lapse in professionalism. And the binary interpretation process is in contrast to the growth mindset. Another problem with a binary interpretation of professionalism relates to the fundamental attribution error. This is a concept in psychology that says that if something bad happens and it was due to someone else's behavior, the cognitive bias is to say that that is due to that other person's personality rather than the situation. So, that other person was late because he mustn't be very responsible. Whereas in reality, it was a circumstantial issue. The situation was it was raining really hard. In contrast, according to the fundamental attribution error, if something unprofessional happens due to our own behavior, we say, well, that was just circumstantial. I'm actually a good person. It's not my fault, but something around me happened that led me to be unprofessional. So this concept of fundamental attribution error is one that we all want to recognize in ourselves as a natural tendency. If something is not desired as a behavior from someone else, try to resist saying, oh, they're unprofessional, and instead inquire what was happening, what was going on, what were you trying to accomplish, what interfered with the thing that you were trying to accomplish. So we move focus from the person and their traits toward the behavior and the situation. If we too strongly lean on professionalism as a list of behaviors, and I'm not saying that we don't want to articulate what professional behaviors are, but if we go too far in emphasizing only the list of behaviors that can be punished, we can really create a situation that lacks psychological safety and lacks opportunities to emphasize growth. When people fear that they will be punished as either unprofessional or unprofessional and having bad professional traits, that creates a fear-based negative workplace culture that undermines intrinsic motivation, inhibits people's creativity and individuality, even though we may be admitting people in an effort to create a diverse environment. This scenario also promotes surface level, minimally acceptable behaviors. I'm only going to do what I need to do to appear professional to you rather than to be professional. This leads to a lack of context or nuance, disengages people, and may lead to punishment over support, and in the end fails to address the root causes of unprofessional behavior. So we need to use caution and pull back singular emphasis on teaching professionalism as a list of behaviors that could be punishable. Let's move now to discuss some of the generational issues with professionalism. Even before we started today's session, when we were in the waiting room, we were talking about how professionalism seems to have changed since we were in training. So it's extremely tempting to fall into generational explanations for the problems with professionalism that we observe today. You catch yourself in this generational trap when you hear things like, when I was a resident, when I was a student, kids these days, in the days of the giants, things were better. There are some truths about how things were when we trained compared to today, but there are also many myths about the generational differences. So rather than lean on generational explanations for challenges with professionalism, it really is better to appreciate that different people have different approaches to their work and that all of that will vary with the particular circumstance. Some authors advocate that instead of chalking things up to generational differences, that we actually frame this as a communication problem, that we need to learn and overcome feelings of generational difference by being curious and being open, asking questions, trying to understand why someone of a different generation might be viewing a situation differently. So that really invites our own humility. We also need to have caution about our own memories. Each time we recount a memory, we aren't actually replaying it. We are reconstructing it. So we're good at remembering the gist of an event, and we're also good at filling in the details with the narrative that seems most salient today. One of my colleagues at UCSF, Gurpreet Dhaliwal, wrote this article called The Greatest Generation. And he's describing how it's easy to remember fondly and yet incorrectly how things were with our generation when we were in training as the greatest generation of trainees. He writes, "You weren't that great. Critiques of the modern trainee start with kids these days and lament but inevitably end with the days of the giants nostalgia. When I was a resident, I held vigil at the patient's bedside all night long. When I was a medical student, I would admit 4 patients on a call night and never, ever complain. When I was, da, da, da. These are all inspiring stories, but they probably aren't true." So instead of falling into the generational trap, think about your own curiosity, your own humility, and how you might bridge the gap through communication strategies. A helpful book for thinking about what you may be perceiving or observing as generational differences is the book 10 to 25, The Science of Motivating Young People. This is a book by David Yeager, who's studied under Carol Dweck, who is known for the concept of growth mindset. And David Yeager advocates that we all have a mentor mindset when we are working with young people. The key to the mentor mindset is it combines high standards. He's not saying lower your expectations, lower your standards, but combine that with high support. So how do you show high support? You validate learners' perspectives. Whether or not you agree, you are validating their existence. You are showing respect. You are asking questions, again, being curious. And you are creating space to share your own perspective. A key quote from David Yeager is about how to give difficult feedback in a way that combines the high standards with high support. His line is, I'm giving you this feedback because I have high standards and I know that you can meet them. I'm giving you this feedback because I have high standards and I know that you can meet them. That is what he describes as wise feedback. So if you are not in this mentor mindset ideal place of communicating your high standards in combination with your high support, where are you falling on this chart? If you are in the enforcer mindset in the upper left, you are coming off as being punishing. You have high standards and low support. This is where many of our learners might say they feel like their supervisors are around professionalism. Other mindsets, the protector mindset, too much support, so much support that you are lowering your standards and conveying that you don't really think that that learner can do it on their own. And then the apathetic mindset is basically ignoring or giving inadequate attention to our learners. So this concept of the mentor mindset really builds on the concept of a growth mindset. And in the space of professionalism, we want to encourage our learners' professional growth. And we may also need to think about our own professional growth. How can I understand professionalism in the modern environment rather than having a fixed mindset about what professionalism used to look like in the days of a giants when I was a trainee? So we want our learners to understand if something they did was not perceived as professional right now, how did that come about? How can we convey to them, I'm sharing this feedback because I have these high expectations and I know that you can meet them and we can work together to make a plan. Mindset theory, growth mindset being the classic epitome of mindset theory, really emphasizes that mindsets are changeable. They are malleable over time. So some people say, oh, medical students, residents can't have a growth mindset because it's so competitive to get into medical school that they must have a fixed performance mindset. But the good news is you can shift that mindset by emphasizing and valuing growth. We do that as educators by watching for and rewarding effort. I saw that you were wrestling with this professionalism dilemma and you were seeking feedback or you were looking at the situation from multiple alternatives. Those are excellent, productive efforts to your own professional growth. That would be an example of how to encourage changeability and growth around professionalism in the way that you give feedback and unpacking the nuance and the contextual components of professional behavior. The third aspect of professionalism is equity. Many learners will say that they feel that who defines what is professional is at odds with what they or their community might see as professional. Learners tell us that what we state as our expected professional behaviors is not necessarily what they see happening on the ground when they are interacting with our clinicians. That is the hidden curriculum. And many learners will say that what is viewed as professional is information that's available to some people, maybe people who came from a medical family or background, for example, but isn't explicitly articulated for all learners. So they don't know what they don't know until someone tells them that they're not behaving professionally. The hidden curriculum can be positive or negative. Most of us, when we hear, oh, there's a hidden curriculum, think there's something bad and nefarious happening. But we can steer the hidden curriculum to reinforce the professional behaviors that we want our learners to adopt. So on this slide about the hidden curriculum, you see in the top left, medical students start medical school very enthusiastic and optimistic, as we discussed. And if the hidden curriculum is emphasizing a unsupportive, unprofessional environment, students will feel stressed. They'll feel rewarded only for how they do on their medical knowledge exams. They will not be rewarded for how they communicate with patients, and then they will find themselves labeled as unprofessional by a future clinical supervisor. In contrast, we can design our curriculum to promote a hidden curriculum that emphasizes professionalism through things like early exposure to actual patients, to support during transitions in the curriculum, through emphasis on well-being. So think about the hidden curriculum or all of the environment and experience factors that might be shaping our students' view of professionalism. And think about, from an equity perspective, how all of this information may be more clear and more available to some learners than others. We did a study at UCSF called The Problem and Power of Professionalism, where we interviewed learners from minoritized backgrounds and non-minoritized backgrounds in terms of race, ethnicity, to ask them about their experiences with professionalism. And we heard from learners from underrepresented minority groups that professionalism often exerted oppressive power and perpetuated white cultural norms. In contrast, some participants who were mostly self-identified as white had not even considered that professionalism might be oppressive and couldn't really recall examples where professionalism had negative consequences or interfered with their training. So each learner's experiences are different, but we did find that among minoritized learners, they had much greater and more specific and poignant examples of where professionalism could be oppressive and lead them to feel that they had to hide who they were or had to behave in a way that would please other people rather than being true to their identities and backgrounds. So I'd like to wrap up by suggesting 5 recommendations for promoting positive professional behaviors among our learners. The first is to emphasize core communication skills, and this is for our learners, but also for our faculty. Thinking about those 3 frames of the virtue-based, the behavior-based, and the professional identity formation, all of those are at play in the way that we emphasize core communication skills. From the beginning, orientation is not just about your class schedule and the map of the institution, but also about the values and the way that we interact. We introduce doctor-patient communication skills for our students during orientation week so that they can learn to interact with one another in the way that they will interact with their future patients and teams. Establishing coaching relationships or some kind of relationship with a senior physician where the learner is actually able to feel safe to talk about where they are in their learning and how to respond to difficult or constructive feedback in a way that feels psychologically safe is very important to nurture that growth mindset. Setting up peer relationships that promote respectful dialogue, having lots of opportunities to receive, to give, to respond to feedback are important, and encouraging perspective taking, moving away from that binary unprofessional, professional toward the nuance of a situation and why people might have seen the same situation differently. Recommendation 2 is to anchor professionalism to patients and teams. This allows us as professionals to fulfill our contract with society. When you look up the physician charter for professionalism, it's certainly written, I think, with language that might lead people to be concerned about how professionalism can be defined in ways that let people who already have power hold power. But the basic concept that physicians have the purpose of serving our patients and communities is very much relevant to the way that we should be framing professionalism for our learners. We have found at UCSF that we enact this concept of contract with society through the construct of patient advocacy. That is a term that our learners helped us develop as a way to say, when you are spending extra time with patients and families, when you are helping patients who maybe have a similar background to you to understand what's happening with their care or how physicians approach clinical problems, that is what our learners define as patient advocacy. And our learners from underrepresented backgrounds say that that is one of the strongest ways that they advocate in an equitable way for their patients. A third recommendation is to have a strong emphasis on professional or physician identity formation throughout the curriculum. We found that the term physician identity formation landed a little better with our learners at the time that they were most concerned about the term professionalism being weaponized. But whatever way you capture it, the concept is about how students come to think and act and feel like a physician, showing that you see this as a process that integrates what they bring to medicine and what they are learning through their training. When there are crises like the COVID pandemic, or perhaps like what's currently happening nationally, those are key times where identity formation evolves. So there are ways to use those crises to focus on what's happening, to talk about it, to help learners connect that to their growing physician identity. So leveraging times of disruption, of crisis, and thinking about those actually as good times to focus on professional identity formation is a strategy. The fourth recommendation is to build feedback literacy. We tend in medicine to talk about giving and receiving feedback and to talk about it as a skill that faculty need to develop and a message that learners need to be able to receive. But the literature on feedback would say that really feedback should be a dialogue and that both learners and faculty need to develop feedback literacy. Learners need to learn how to seek feedback, how to appreciate it, how to interpret and refine it and judge it, and to process their emotions at the same time. Teachers need to learn how to craft their feedback in ways that it will have maximal impact for learners and be sensitive to the emotional and relational aspects of feedback so that there can be the setup for ongoing dialogue. That's why the circle in the middle of this slide illustrates that feedback is an ongoing process, and we need to prepare both our learners and faculty to have robust feedback literacy. My last recommendation is to emphasize a coaching approach. Some schools, some people are appointed as coaches in ways that is a very formal position, but really all of us can use a coaching approach with our learners, with our colleagues, with our patients. A coaching approach emphasizes skills like asking questions, listening with humility, and being curious. The idea here is that the learner may have many of the answers about what happened or what might go better next time if we create the space for them to articulate that information. Many clinicians are familiar with appreciative inquiry. The appreciative part of appreciative inquiry is that we are taking a strengths-based approach, appreciating that the learner is bringing many strengths to the situation. And so we want to take a collaborative rather than top-down approach to finding a way to understand what happened and creating a path forward. The Vanderbilt cup of coffee approach is a nice way to start with coaching when there is a lapse in professionalism. Most of our learners would think, oh, if there's a lapse in professionalism, you're going straight to the top of the pyramid, level 3, where there's some kind of negative intervention and some formal punishment process. But that should really be rare. Most interventions around professionalism should be at the bottom of the pyramid. And that's where the cup of coffee is one way of saying, just sit down and have a conversation and use those coaching skills. What happened here? What was your perception? What do you think other people might have perceived from this situation? How might you have handled it differently? How might that have landed on the other person? And hopefully things improve from there. If you escalate up the pyramid, that might be because something was egregious or because there's an apparent pattern of behavior. And in those cases, you need stronger interventions, usually with someone even more skilled in those kinds of coaching or perhaps corrective conversations. The point here, though, is you want to start at the bottom with an open coaching approach, and most people will respond well to that. So in summary, we've talked today about the fact that professionalism is not just the absence of bad behavior. It really is the development of a physician identity. And you might find helpful the 4 I's as one framework for defining professionalism in a way that's understandable for both learners and faculty. Avoid generational tropes that oversimplify a complex construct and tend to be disrespectful to learners. Be curious, ask questions, and coach in a dialogic way. Reinforce the 4 I's of integrity, interaction, involvement, and introspection, and continuously support professional physician identity formation. So with that, I will take down the slides and I invite your questions or discussion. Thank you very much.
Karen, I wanted to say thank you so much for that construct on how to teach professionalism. I did have a question for you do you at UCSF have a similar program for faculty? I know you focused on medical students and the trainees, but do you have any approach that you suggest for new faculty who are joining straight out of training on how senior faculty could teach different aspects of professionalism as they build their practice and build their research careers?
I think we have multiple approaches. One would be assigning a mentor to a new person. Another would be in one of our programs, we have found that new faculty want 2 mentors. They want a senior mentor and then they want a peer mentor so that they can have a place to talk about things with someone at their level. So those would be in the identity formation category. Others that are more like behavior-based or more rules-based would be like onboarding programs where, everybody's going to come together and learn the rules here and learn to practice those things. And then I think honoring new faculty or celebrating their advances might fit in the virtue-based approach. But we have found different kinds of mentoring from different levels, I think addresses the different needs and helps bridge some of the generational differences. The opposite is the approach, like young faculty are only thinking about, how much time they get off. And when I was young, we worked as long as it took. Those kinds of comments are unhelpful. And sometimes if you hear them, it's good to try to think, how can we intervene with that person and maybe coach them a little differently around that negative messaging.
I think Dr. Atipur just had a comment. I'll just read out to the whole group. We need to shape our training systems and clinical workplaces in a way that allows physicians to still feel a sense of meaning, calling, and connection to why they entered medicine in the first place, despite the pressures of bureaucracy, metrics, and productivity-driven systems. And I think that is a challenge for a lot of faculty, as many academic centers turn to a very RVU-based system, as is ours. And Karen, do you have any suggestions, helpful hints, or pearls?
Yeah, we're feeling all the same productivity pressures at our place. It's interesting in my clinic, the nurses do these daily huddles where they come in the hall and they have certain like quality improvement initiatives that the clinic has to continue to make progress on and show the health system. But as part of that, they like celebrate different nurses who've had little accomplishments. And it might be like a patient in the feedback card about the survey after you've come to the clinic praised a nurse. So they'll do a shout out to that nurse. And seeing all those nurses come together and do that, like when they read the shout out comment, they all like clap in the hallway. And it's just really cute. And I think like physicians wouldn't really do that, but it's pretty nice. And you can see the nurse who got the shout out, feels proud. And that's reinforcing the kind of professional behavior that you would want nurses to demonstrate. So building in little structures where teams could discuss a difficult situation or give praise to positive professional behaviors. I think those are easy, inexpensive things to do that really only take a few minutes a day that can emphasize the importance and also of professionalism and also contribute to people's well-being. So many of you on this call probably lead teams. So thinking about how you might build that into rounds or build that into a clinic huddle.
Thank you. Does anyone else have any questions or comments?
Amisha had a question.
Hi, Julie.
Hauer. Hi, nice to see you again.
You as well.
So I'm wondering, you had asked the question at the beginning about, the challenges in teaching something like professionalism and, in developing curriculum and thinking about like backward design and trying to come up with the objectives and the assessments first. We always find it challenging to think of, a variety and appropriate level of assessments to, determine competency and professionalism. And I think there's like quantitative approaches where you could look at, say, number of professionalism reports or incident reports on faculty or students. There's for students, we have OSCEs where we can kind of try to judge that, or we have faculty evaluations of students. But are there other ways in which you have found effective in being able to assess professionalism?
Yeah, I think a couple of thoughts. Like it's important to distinguish, are we assessing professional behavior or are we doing something that's capturing unprofessional behavior? And just being clear with yourself. Like in our CPX, we did add a category of unprofessional behavior that the staff captured because we were hearing like students who got good scores on the CPX were showing up late or not being professional in their interaction with the staff. So that was a conscious decision. We need to know if people are behaving differently with staff than with faculty or with standardized patients. So being clear on that distinction is important. I think another one is asking people to assess the professional behavior that they can really see. So putting 10 professional behaviors on a clerkship evaluation form and asking faculty who don't really know to assess all these things diminishes the appreciation for the construct of professionalism. So tailoring what you're asking people to do is another one. And then I wouldn't say we fully figured this out, but really to assess professional development, something like a portfolio system or an individual reflection that captures the learner's perspective in a more in-depth way would capture what we really want to know. We do that through these we call our inner sessions in our curriculum physician identity formation weeks, and the learners have different reflective type activities that they do in small groups that feel like they're getting closer to what we really mean by professionalism.
Thank you. That sounds like a more holistic approach and trying to
Yeah.
get us.
And that's where people can showcase like how their background, their personal background, the diversity that they bring to the institution relates to their developing physician identity.
Thank you.
Does anyone else have any other thoughts or questions they'd like to share with the group today?
Actually, I thought I would ask, what do you think about professionalism? What's the most controversial or difficult part that gets missed in translation that we all should be thinking?
I think that professionalism is a term for finding bad behavior. I think that's just really common now, or that professionalism is a way to try to get other people to be like some outdated physician perception. Yeah. Mm-hmm. Instead, we should lean in and say, yes, the definition of a professional is changing, and we want to build it with you, and we want it to be modern, and we want it to reflect that there are productivity pressures and that physicians are a more diverse workforce. And in the past, we can capture all of that and create something, kind of create or co-create something more positive.
I found it interesting because there are issues of training graduate students and professionalism in graduate programs as well, and it's the very similar parallels, in fact.
But we hear that at our place too. Yeah. Mm-hmm.
It was we have co-mentors, and in fact we have senior and junior mentors, and we've instituted awards for mentorship, and I think we could maybe add an award for. Do we have an award for professionalism, Namisha?
I think we need to.
Maybe we could.
Yeah, we do. So if anyone wants to see how that process works, you're welcome to reach out to me.
I like that. I think we will do that.
Yeah.
Any other questions from the folks in the audience? Okay, because it is we're closing on our 1 hour time, so I want to thank everyone. I want to thank Dr. Hauer for presenting tonight and taking her time out to do that. And a plug for next monthly on Monday is Navigating the Academic Journey with Family Support. So that is May 12th. Hope to see you all then. Thank you and good night, everyone.
Thanks, everybody.
Thank you, Karen.
Thank you.
Bye.
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 Thank you.